Good afternoon, and welcome to the 19th now of our Town Hall series. It's really great to see all of you again, and I want to thank, as always, the Society for Leading Medicine, Jeremy and Caroline Finkelstein, Catherine and George Masterson for their chairmanship of that, and all of your tremendous support. You know, over the last couple of meetings now, we've been able to talk about a little better time, obviously, in the COVID pandemic. In fact, really, at this point, looks like COVID is moving from a pandemic phase to an endemic phase, with the caveat being, of course, none of us have a crystal ball that's perfect. And it's a delight that that is obviously happening right now. And that's enabling us to really shift this Town Hall series a little bit from, you know, all COVID all of the time to focusing on some of the other wonderful things that are happening at Houston Methodist. We will continue to talk about COVID as well, and in fact, Dr. Sostman and I both will talk about kind of a future in endemic COVID, but today we're going to get to hear from two of our wonderful leading surgeons here at Houston Methodist, Dr. Mike Klebuc and Dr. Eugene Alford, both of whom are going to talk to us about reconstructive surgery. I want to thank Claudia Contreras, who heads up the Reconstructive Surgery Task Force. If anybody's interested in that task force, I know they're always happy to have some additional members. You can email or you can get in contact with us about that. So we're going to start with Dr. Mike Klebuc first and then move on to Dr. Alford, and then you'll hear from me and Dr. Sostman after that. If you have questions, by all means, please bring the questions to the chat so that we can ask that of these gentlemen. Thank you.
Well, thank you, Dr. Boom. It's really an honor for me today to talk about some recent advancements in reconstructive surgery, and I thought I'd share a little bit about the history of plastic and reconstructive surgery with you initially, and that it dates back to the Renaissance, specifically to a surgeon named Gaspar Tagliacozzi, and I think he states the mission quite nicely when he said our goal is to restore, rebuild, and make whole those parts that nature have taken away, but the parts that nature hath given, but fortune has taken away. And at the Houston Methodist Institute for Reconstructive Surgery, that's really our mantra. Our goal is to restore form, function, in an effort to enhance quality of life. I'd like to start off by touching on something that I'm really interested in, and that is the surgical rehabilitation of the paralyzed face. You can see that injuries to the facial nerve create a series of both functional and aesthetic problems. You lose your protective blink, and so the eye can become damaged. You can lose vision. You have difficulties keeping food and fluid in your mouth, which is a problem. You have obstructive nasal breathing, speech is impaired, and of course, from an aesthetic standpoint, this is really disastrous for this young lady. And so we try to come up with a plan to deal with different zones of the face in an independent fashion and to do our best to match what's happening on the contralateral unaffected side. This is a procedure that was developed here at Houston Methodist Hospital and is really diffused all over the world and become a gold standard procedure, and we're very proud of that. And it's a way that we can restore a smile. We can actually take a chewing nerve, the descending branch of this chewing nerve named the masseter nerve, reroute it to the facial nerve in an effort to restore an active smile. And this young lady has had an acoustic neuroma brain tumor removed a year ago, and you can see that the right side of her face is severely affected. And here she is after the masseter to facial nerve transfer, where we were able to restore an active smile for her and do it in a timely fashion so that she could enjoy her big day. Sometimes the muscles of facial expression aren't available. They've undergone irreversible atrophy or they've been damaged by radiation, and we have to bring in a new source of muscle. And here's a young lady. She's been paralyzed now for over 2 years, and the decision was made to import a new source of muscle to rebuild her smile. The muscle that we obtain is called the gracilis muscle. It's a sliver of muscle from the inside of the thigh, and we take the muscle with its nutrient blood vessels and its nerve, and we transplant it using microsurgery. So here we are in the operating room working under the microscope, and the stitches we're using to unite this blood vessel are the third the thickness of a human hair. If I was to see one of you in the emergency room with a cut eyelid, I would use the stitch on the right to do it. If I was to fix your facial nerve, I would use that minuscule suture on the left. Here's this nice lady now, 8 months after surgery. with some restoration of her smile. Sometimes we also like to import nerve signals from the unaffected side of the face, and we do this using long nerve grafts. This young lady has a unilateral developmental facial paralysis, so she was born this way. And we will use long nerve grafts to import function from one side of her face to the other side of the face and to power one of these muscle flaps that I just showed you. Here's our surgical plan, and here she is after completion of the surgery. And the beautiful part of this type of reconstruction is if you're joyous and happy, then the signal goes from the unaffected side across to the affected side, and it just has to come along for the ride. So we also have the ability to restore eye closure, which is important if you'd like to avoid visual loss. And we have some simple yet elegant techniques for this. This young lady, again, has lost her protective blink. She can't completely close her eye, as you'll see in a second. But by putting a small wafer of platinum or gold under the skin or the muscle of the eyelid, we're able to restore complete eye closure for her. I'd like to switch gears now and talk a little bit about the surgical prevention of blindness, especially with a new technique called corneal neurotization. These procedures are being done in conjunction with Dr. Amy Coburn of the Ophthalmology Service, and we've been working on this program for about 5 years. If you develop corneal anesthesia, you have no sensation in your cornea, you will ultimately go on to severe visual loss and usually permanent blindness. The main causes are brain tumor resection and zoster infection, like herpes zoster infection or shingles. Traditionally, we've dealt with this by just stitching the eyelid shut to protect the eye or using copious amounts of ointment, but even corneal transplant does not work in this patient population. This is the perfect storm if you have a situation where your facial nerve is affected, you can't blink, and you have no sensation in the eye, then you're really in trouble. This is Dr. Coburn. She's testing the sensation on this young lady's eye. And this is the surgical procedure we perform. We divide a sensory nerve on the opposite side of the face. We connect it to a long nerve graft that traverses the face. Then we break the nerve graft into its component parts called fascicles. We wrap those around the eye and then insert them into small pockets at the periphery of the cornea. Over 14 to 16 months, those little nerve fibers will traverse the graft, bring in new sensation to the eye, and not only that, they'll deliver growth factors and certain chemicals to the eye that help maintain the health of the cornea. We, again, have been performing these surgeries for the last 5 years, and this program was developed with the kind support of the Dyer Foundation and the Dunn Foundation, so thank you very much for that. We'll switch gears and talk a little bit about head and neck reconstruction. We're very blessed at Methodist to have a lot of talented people that we can interact with to make multidisciplinary teams. And I frequently work with the oral maxillofacial surgical service, neurosurgery, ENT, vascular, and interventional radiology. This is an amazing new technology that we have here. It's called a computer-assisted design and computer-assisted modeling, which is allowing us to do reconstructions to the precision of a millimeter, which we could never previously do without the computer enhancement. This young gentleman has a benign tumor called a maxillary osteoma, and you can see here on the CAT scan the opaque areas where the tumor is. And certainly that will continue to grow, and he'll become profoundly disfigured if he's not dealt with. So this is virtual surgical planning. With the aid of an engineer, we plan to remove the area that's in the red. We can create 3D printed cutting guides to allow us to precisely remove only affected part of bone, leaving the normal tissue behind. We can use the same technology also to engineer small little pieces of bone from the leg, from the fibula bone, along with its blood vessels. We cut them like little jigsaw puzzle pieces and fold them up like origami to create a new midfacial bone. And of course, we connect the blood vessels as I previously showed you. Even more interestingly, we can now 3D print plates out of titanium. These are rigid and they hold the bone in place during the initial healing. It's hard to imagine, but we have actually replaced the entire midface on the left side. So the cheekbone's been totally replaced on this young gentleman. And the only thing you can see externally is a small 2-centimeter scar on the side of the neck, something you might see if we removed a mole. This is his follow-up imaging. You can see that the bone has been replaced, and certainly we'll put in dental implants to complete his rehabilitation. I'd like also to discuss skull-based surgery. We have an active program here. This gentleman had a very large atypical meningioma brain tumor that was growing through the base of the skull and actually into the nasal cavity. Using virtual surgical planning, this is some very powerful technology we have here at Houston Methodist, we were able to put together a very effective plan for this gentleman. And using CT scan data and MRI data, we're able to create these virtual models which allow us to actually fly into the cranium and see where the tumor is, where it is in relationship to vital structures that we must preserve. It also gives us an idea of what will be missing once the tumor is completely resected. So in this case, the tumor is all in green, and we'll take a journey inside the cranium, and you can see the relationship of the tumor to all the important nerves and blood vessels in that area of the cranium. Here we are in the operating room, and again, this is a multidisciplinary effort. Dr. David Baskin, the neurosurgeon, is working at the microscope to remove the tumor from above. Dr. Mas Takashima from Otolaryngology is removing the tumor from the nose from below, and I'm harvesting a piece of muscle with its blood vessels for microvascular transplantation. And the reason we're doing that is we have to separate the brain from the nose and the mouth in the external world, otherwise the patient would succumb to meningitis in 48 to 72 hours. So again, we used microsurgical techniques to transplant this muscle, and you can see here that we have effectively separated the brain from the external world, the nose and the mouth, which is critical to his survival. We were thrilled that the Houston Chronicle felt that this was a compelling story that they recently published, so that people in Houston can see the work we're doing at Houston Methodist. This was a surgery performed here in Houston Methodist in 2015, and it was a world's first. We did the world's first skull-scalp transplant, and at the same time we also transplanted the kidney and pancreas. This was a joint effort between MD Anderson Cancer Center and Houston Methodist Hospital. The gentleman had previously had a kidney pancreas transplant, which was wearing out. He needed new organs, but unfortunately had a complex wound on his scalp which would not allow him to be listed for a new transplantation. So we found ourselves in a catch-22 position, and we decided to take a novel approach, and that was to do a triple transplant from one donor. So skull, scalp, kidney, and kidney and pancreas, all from one donor. This is Dr. Josie and myself performing the skull-scalp transplant. And here is the gentleman just before discharge from the hospital. And this story was released, and it caught the attention of the world, I would say. And when it was all said and done, almost 1 billion people saw this story through different media outlets. So it was very, very gratifying. And here he is in long-term follow-up, and continues to do very well. So the last thing I'd like to touch on is something incredibly exciting, and it's some new research that we're hoping to start performing in Houston Methodist in due course. When a peripheral nerve gets injured, so if you accidentally, for example, cut a nerve to your forearm and you couldn't feel your fingers or flex your fingers or make a fist, we would take you to the operating room, we would stitch those nerves together using microsurgery like I've shown you today, and then we would wait for the regenerative process to happen, and the nerve would grow back typically at 1 millimeter a day or 1 inch a month. It's a lengthy process, and the recovery is always incomplete. You never get back complete motion, and you never get back complete sensation. With this new technique we have called PEG fusion, we are actually able to trick the nerves to fuse back together and restore immediate functionality. This is an example in the lab with a rat. We're dividing the main nerve to its leg, and we'll stitch it together with traditional microsurgery. Here we're using electrodes to stimulate the nerve upstream of the coaptation, and nothing's going on. But we put in this little well, and we treat the nerve with a solution called PEG. We are able to trick the nerve into fusing together in an effort to restore immediate function. And I would say in my surgical career, this is the closest thing to magic that I've ever seen. It's incredible to watch this happen in real time. So we'll put in the PEG fusion solution, then we'll move it, and now with the electrodes, you can see we're stimulating the nerve and the leg is actually contracting and moving. We've been able to get that nerve to function. If we take these little fellows and we put them on a walking track 2 weeks after surgery, I'll show you what we can accomplish. This is a normal guy. He has not had any surgery. He's prancing to his little house up the ladder. This rat has had the nerve cut and repaired traditionally, but no fusion. And you can see the leg is starting to fail and he has a deficit. This rat has been treated with the PEG fusion and he's traipsing home just fine. So we have just been selected to become the principal investigators for this technology at Houston Methodist Hospital, and the other participating sites are seen below. And I just want to thank everybody for their kind attention.
Wow. Thank you, Dr. Klebuc. Fascinating stuff. We're going to do some Q&A in a few moments, but first we'll hear from Dr. Alford, and then we'll do a little Q&A with the two of you. Dr. Alford.
Thank you, Dr. Boone. Well, after seeing Dr. Klebuc and his work, he is too humble to tell you that he is one of the world's preeminent plastic surgeons and the considered world expert at reanimation of the paralyzed face, and that's only through very, very hard work and skill. My talk's a little bit more about facial plastic surgery, and I want to talk about the past, what's going on in the present, and then what we expect and hope to do for the future. The Department of Plastic Surgery was formed in 1956 by Dr. S. Baron Hardy, who was one of the founders of the Board of Plastic Surgery. However, there's been a very collegial relationship between otolaryngology, which is my background, and the plastic surgery department here at Houston Methodist Hospital. Dr. Melvin Spira took over the department chair in 1976, and he was a dentist who trained in Chicago. He had a friend who moved to Houston, William K. Wright, who was an otolaryngologist, who had a special interest in the nose. The two of them worked together to write some of the very first papers regarding nasal surgery and had a very close collegial friendly relationship for many years. Dr. Wright passed away in 1996. Dr. Spira died last year, and they are giants of the field whom we miss greatly. I joined the hospital in 1991 when Dr. Bobby Alford recognized the need for reconstructive surgery here at Houston Methodist. And so I was the first otolaryngologist to be trained in microvascular free tissue transfer here at Houston Methodist, an area traditionally reserved for plastic surgery. When I arrived here, in order to get my hospital privileges, I got those from Dr. Spira, not from Dr. Alford, and he was so open and collegial to me that we began doing microvascular free tissue transfer here at Houston Methodist. And so this is a lady who has a very large basal cell carcinoma of her cheek, and then you'll see that it goes all the way through her jaw into her mouth, and at surgery we had to remove the left half of her jaw all the way to the midline. We then, as Dr. Klebuc showed you earlier, used a fibula free flap along with its nerves, arteries, and veins, transplanted it from the leg to the mouth, reconstructed the jaw, hooked up the arteries and veins to the nutrient vessels, connected a nerve so that there was sensation to the skin, and then here is the before and after photo. On the left, she could not eat, she could not drink, and on the right, she eats a normal diet. While I would love to be able to reconstruct her lip, she's very happy with the way she is and is alive and well today. These photographs you look at here were taken in 1994. As we moved on in the collegial relationship, I worked with Dr. David Netcher for all of these free flap reconstructions. and we treated more than 150 patients in 10 years. Our functional and cosmetic results improved dramatically. This is a before and after picture of a young lady on the left. She has a very large floor of mouth cancer inside her mouth. And on the right is 6 months after surgery, in which her whole jaw from one corner to the other corner were removed and rebuilt with a fibula flap. She has some postoperative swelling and redness from radiation therapy, but I think she actually looks better after surgery than she did before. There was a tremendous improvement in our skill. We had much better patient care and outcomes. We presented several papers on our outcomes, and our collegial cooperation grew throughout the years. Now, we weren't doing just free tissue transfer. Here's a young lady that came to see me 5 years before this photo. She had been a former runway model in California and had had a problem with intranasal issues. She had a hole in her septum, and I repaired the hole in her septum, did a rhinoplasty, repaired a saddle nose deformity, and then 3 years later she developed an infection in which you can see in the photo on the left, her nose is very red, the skin is dying, and then in the photo on the right from the side view, the tip of her nose is dyed and essentially fallen off. So how do we repair that? We use something called a Paramedia mid-forehead flap, where the tissue from the forehead, based on an artery above the eyelid, is transferred down to the nose. In this particular patient, we had to transfer the flap so far, we did something called the delay process, where you elevate the flap, put it back down, and then 3 weeks later transfer it to the nose. So here's a series of photographs on the left before surgery. In the middle, the flap is transferred from the forehead to the nose, and then on the right is 1 week after the flap was divided. And then these are, again, photographs from the side showing the same views: infection, flap down, flap divided. And then here she is with 10-year follow-up, and her nose is not collapsed. She breathes well, and no one really knows what happened. Many of you know about Carolyn Thomas. Carolyn was a survivor of domestic violence. She was assaulted by her boyfriend, and this is the way I met her in November of 2004. Her mother was killed. She had no insurance. She had been living with this bandage for 14 months. And I would caution you, in just a moment we're going to see a photo of her without her bandages, but she's missing her right eye, all of her left cheek, her upper jaw, and all of her nose. So she was referred to me by the National Coalition to End Domestic Violence, who provided pro bono reconstructive services. She'd been turned down by 9 doctors across the state of Texas, and I was sort of the last resort. I knew that I could not take care of this patient by myself. I'm a really good surgeon, but we really needed a group to manage this. So myself, Dr. Charlie Soparker, Dr. Cohen, Dr. Jeff Friedman, and Dr. Mike Klebuc undertook 7 surgeries over 10 months with $2 million worth of free care to reconstruct Carolyn's face. It resulted on me being in the Oprah show twice, the Larry King Live show twice, and $37 million in free PR for Houston Methodist Hospital. So here's Carolyn the day I met her, and this is Carolyn on the right after 7 surgeries over 10 months here at Houston Methodist Hospital. And Houston Methodist was the only hospital in the state of Texas capable of providing this level of pro bono free care. Dr. Klebuc set the base for us by using a fibula to reconstruct her upper jaw, and then 6 other surgeries to rebuild her whole face. Carolyn lives in Waco now and is an advocate for domestic violence, or ending domestic violence. Today we do not only reconstructive surgery, but here is one of the coaches from the Rice basketball team. He's broken his nose several times. He can't breathe. He's going to get married this summer. He wants to look good for his wedding photos, so we straightened up his nose. Here's a lady whose nose plunges every time she smiles. She can't breathe, so a rhinoplasty. But then the most challenging patients are really what we refer to as the Michael Jackson noses. These are people who've had extensive nasal surgery when they were younger. Their nose now completely collapses. They can't breathe at all. They don't like the way it looks. We take cartilage grafts from the ear or from the rib and then rebuild the nose, and these photos are 1 year after surgery. So what does the future hold? Let's see if we can get this to advance. Can someone advance the slide? We've got 2 more slides. There's one more, another Michael Jackson, and then the last one. So the future, how are we going to fill the need for the areas of facial plastic surgery? You know, we do a wonderful job of training our residents here at Houston, but we'd like to increase their independence when it comes to facial plastic surgery. We want them to be an integral part of the planning. We want them to be able to make the decisions, gain firsthand experience to enhance their skills and improve their outcomes. We do not have a public hospital where they can be that independent. And when a patient comes to Houston Methodist, they expect someone with experience to do all their surgery. We want to create a new training paradigm of a facial deformities clinic that provides pro bono care, that residents are in control. Staff, me, is going to supervise their surgery. They'll have surgery 1 Friday per month. We'll have clinic in my office 2 Fridays per month. Hopefully, at some point, we will be able to create this educational paradigm shift so that we can improve the training of our residents and maintain the specialty of facial plastic surgery within the plastic surgery department here at Houston Methodist. Mark, thank you.
Thank you. Thank you, Dr. Alford. Thank you both. Really fascinating look at what's happening here. I mean, those before and after pictures, they're mind-boggling. The return of function, the return of confidence, the return of aesthetics that you bring to everybody. It makes a world of difference, I know. So one of the things that struck me is both of you talked about teamwork, collaboration. I'm thinking of the Carolyn Thomas. I counted 5 physicians alone. But you work with huge teams across the skull transplant that you talked about. Let me ask, I guess you first, Mike. Talk about that collaboration, both in terms of how that interdigitates across specialties, but also all the other people, not the doctors, but everybody else that's there. I mean, I saw a picture of that operating room for you that had, a cast of thousands
Sure.
in that operating room, and then how the facilities and other things enable that to happen here.
Exactly. So a lot of it comes down to logistics too, right? Getting all the people in the right place at the right time, all pulling in the same direction. And that's a challenge. But at the same time, I think we have the right culture here where everybody wants to do the right thing, wants to collaborate, and because of that, we've been able to really take on some of these big challenges. And it comes down to just our culture, I think, at Houston Methodist that allows us to do some of these things.
So some of those procedures that you each talk about, you mentioned Carolyn Thomas, I think you said 7 surgeries? Is that
7 surgeries over 10 months.
Over 10 months. But how long are some of these procedures that we're watching? I mean, Dr. Alford, are we talking, a couple hours? Are we talking about, 18, 20-hour operations? What are we talking about?
So when I first began doing microvascular surgery, they would commonly be 18 hours long. With development of skill, not only by the physicians, but also by the nursing staff, we could be finished in 8 to 10 hours. Now, in today's world, with the cutting jigs that Dr. Klebuc talked about, with the computerized planning, the customized plates, all those things used to have to be bent by hand in the operating room, and so the surgery took a lot longer. But the accuracy, the fidelity, the cosmetic and functional outcomes are worlds better today than they were when I started 25 years ago.
And y'all, I heard, one common theme also is sort of repurposing the body. Some things, your science fiction, the installation there to improve the nerve or to reconnect the nerve in the rat was amazing. But a lot of the other things I'm still hearing, they're a free flap, or it's a piece of the fibula, or you took the masseter and moved it. What kind of function do people end up losing sometimes to do this, or are you usually taking things that essentially you can manage around or do without?
No, this has all been carefully worked out over years of research, right? That we know, for example, that if we leave 6 centimeters of the fibula bone below, the ankle will remain stable, and that people will remain very functional. And so all of these things have been carefully mapped out over the years, and there's certainly areas of the body where we have functional reserve. We have a little more than we need, and we can borrow from that to bring it to somewhere else. I think it's fascinating. For example, Dr. Boom, I could take you to the operating room today. I could explore your facial nerve. I could cut half the branches that make your eyes close, half the branches that make you smile. In the recovery room, you wouldn't know any different. And it's because we have that functional reserve, we can use it for reconstructive purposes. The same concept of, if you have 2 kidneys, if you had a loved one that needed a donation, you could give them a kidney and do just fine. And so we really try to take advantage of what the body gives us that way.
Yeah, that's amazing. I think so often when people think about the multidisciplinary, huge team, they're thinking kind of that transplant world. Obviously, some of your work overlap with that in the one gentleman, but really the kinds of surgery both of you do are some of the most complex, multidisciplinary, lengthy, multiple surgeries, incredible amounts of planning that happen in our institution.
I smiled when you asked Gene how long the longest procedure he did, because I was thinking, I think the longest I've done in one setting was 22 hours.
Wow.
And then the longest in total would be 46, where we had to take a little break.
Yeah. A little break. I think hopefully a few more.
A little break was needed.
Wow. Well, I want to thank both of you for being here. Keep any questions coming y'all might have. We can handle some of those a little bit later as well. But you're just seeing a taste of some of the amazing things that are happening at Houston Methodist. And our goal with these town hall series, we tried to do this a little bit in the spring, was to start bringing in some other topics as well. And hopefully you'll find those very interesting and inspiring. Kind of have to go back to just COVID all the time this summer, but we are hopefully on a good track with that. So again, thank you to both of you. I'm going to now give you a little update about things at Houston Methodist. I'm going to obviously give you a COVID update, but I also want to give you an update on a few of the other things on broad strokes happening, and that'll be something I'll use these town halls for, as well as to keep you posted kind of at a global level of many things happening institutionally. As I alluded to earlier, and as we all know, things from a COVID perspective in our community have gotten dramatically better. They already were, well on the way last month when we were speaking, and of course even in September we were starting to see some good signs. But we have plummeted, thankfully, and where we peaked at about 857 or so, I think was the absolute peak. We have 127 people in house now, so that's a remarkable decline. Our low point was in June of this year before the big Delta surge at 79 patients. So we're not as low as we've gotten, but our projections look pretty good. And let me show you a little bit of that. I've shown you this before, and this is our internal modeling. And what you see here on the blue line is the actual. Just look at the dark blue line, and then all those other colored lines on that top curve are different timing of when we put in the projections. But if you follow that kind of gold line out, you see we have some pretty optimistic projections. Now the last couple weeks we're running a little flatter and higher than our projections, so we may be seeing some leveling off, but if we level off at this point, we're leveling off at what I would consider really an endemic phase of this pandemic. So pandemic is when this is blasting out of control really around the world, usually with could say an epidemic is when you have something like that, but it's really more regional somewhere. Endemic is when a disease, flu is a perfect example, is there kind of all of the time. It may cycle in terms of parts of the year and things like that. And it looks like, at least for the foreseeable future, that's probably where COVID is going in our community. Now, let me caveat, as I always do, none of us have a crystal ball, and this virus has surprised us a lot of times. And of course, if a variant were to show up, that can change the game very quickly. But right now, knock wood, we don't see a variant lurking out there that looks to have that potential. Could change, of course, but presently doesn't look that way. And if you look at the IHME, this is a big modeling center out of the state of Washington. We've looked at these data before. The top here is the projections around hospital resource usage. So how many people are going to be in the hospital? And the top one is for the U.S. as a whole, and the bottom one is for the state of Texas. This doesn't go all the way back through the entire pandemic, but goes back, about a year. And so you see that winter surge, and then you see, of course, the surge here, which was steeper and bigger in Texas than around the U.S. It's come down in the U.S., but we're starting to see projections and some increase as other areas go through probably smaller surges than we had. But if you look at the Texas data, given the degree we've frankly suffered already as an area, the amount of immunity that's there through both vaccination and through people who had the infection, the projections are looking pretty good. So, one of the messages you'll hear from me is, seize the moment, be smart, be wise, continue to put the right precautions in place, but let's seize a time that is a little more normal, and let's hope and pray, of course, that we stay in kind of an endemic phase moving forward. There's some real reason for other optimism, and one of the big potential game changers always was if we could figure out how to treat people quickly and keep them out of the hospital and keep them from getting severely ill and keep some people then from dying. That obviously would be a huge change. The monoclonal antibodies that we've done so much of have been quite effective, but they're no wonder drug by any stretch, and they're obviously incredibly involved because it does take either a sub-Q injection or an IV infusion, depending on the usage case that you're using, and that takes quite a bit of time, very significantly resource intensive, in every way, shape, and form. So if we had a pill that you could that a physician could prescribe, could be readily available, that probably the federal government will provide for free, like they have done with vaccines and like they have done with monoclonal antibodies, you could reach really anybody who got an infection and prevent hopefully suffering and death. So Merck, as you all saw, has already put in for approval to the FDA. In fact, they gained approval in the United Kingdom, and unfortunately, as has happened so many times during this pandemic, we seem to be behind others when some decisions like this that could really transform the pandemic are taking longer. But the FDA will meet on November 30th, so I would hope that we will see an emergency use authorization for this drug coming thereafter. Dirk will review some of the data, but in rough terms, when they gave it to people shortly after they were diagnosed with this in a higher risk population, they cut hospitalizations by half, and they actually had no deaths in the treated arm. So really wonderful results. And as you all saw just last week, Pfizer announced that they had ended their data safety monitoring board that was there in place for their drug Paxlovid, ended the trial early because the results were so compelling. They had an 89% reduction in the risk of hospitalization and also had no deaths in that arm. So they're now not quite there submitting yet, but they'll be submitting soon. Dirk will talk about this, but these work on different pathways, so it's even possible we may end up using both of them together in some people. Obviously, if you could prevent 90% of people from getting sick enough to be in the hospital and prevent most or all deaths, it transforms the nature of this pandemic, even if we have a lot of infection out there. And so we're really hopeful as we see this. And of course, vaccines continue to be the number one reason why we are doing so much better. At Houston Methodist, we actually will pass 1 million vaccines given within about the next 2 weeks or so, but certainly before Thanksgiving, which is a mind-boggling number. You can see we've given 86,000 boosters to this point. Epic just sent us, unsolicited. Epic is the big electronic medical record used by really the large institutions around the country, and as big as Houston Methodist is, a lot of those clientele are way bigger, and some of them are massively bigger, multi-state systems. And we were number one in Texas so far using or giving vaccines, and in their top 2% across the country, kind of competing with some much, much larger institutions. So again, our team has done a phenomenal job getting people vaccinated. Obviously, from a political side, the Biden administration's rules were announced and went into effect. They're not implemented in terms of the deadlines yet, but went into effect last week. Over the weekend, the part that goes for employers with more than 100 employees that have to either have a mandate or have a testing requirement actually got held basically by the courts. So we'll see how that plays itself out. That did not affect the CMS, that's the Centers for Medicare and Medicaid Services mandate that affects all hospitals. And so we still are under those rules. And of course, Houston Methodist, which led the way, the rules don't really mean much to us because we're already there. One thing I want to call out for you in the rules is we didn't know how this would go, but for those employers under the OSHA rules, they do not have to pay for the testing. So one of the big loud outcries we heard was it was a kind of unfunded mandate for employers, even as we said, look, employers have to play some role, whether it's mandates or testing or surcharges or whatever to push for more people to get vaccinated. So frankly, if I were an employer outside and I had employees who needed to be tested weekly, I'd say it's on your dime. And yet another reason to help stimulate and push the right answer, which is to get people vaccinated so we can bring this pandemic hopefully to a close. Big news, of course, last week is that the FDA and then the CDC have now authorized the Pfizer vaccine for children ages 5 to 11. Remember, that one had been approved for 12 to 16, and then right from the beginning was 16 and up, whereas the others are 18 and up. And that started last week. I can tell you we've vaccinated well over 1,000. And of course, we're an adult hospital system. We don't expect to do tons and tons. I know Children's Hospital, Texas Children's Hospital, has tens of thousands of children that have signed up for vaccine appointments. But I know this is a hot topic, so I wanted to spend a little time reviewing with you some of the slides from the CDC decision making. This is their summary slide, which basically says in that 5 to 11 year age group, their kids are just as likely to be infected. There's been almost 2 million have been infected. Now, of course, we know, thankfully, that it tends to be quite mild in children. That's a blessing in this pandemic, of course. And they estimate seroprevalence maybe as high as almost 40%. So in other words, in this age group, if you do antibody studies, there may be as much as 40% of children who have been infected. But there's still a significant risk of severe illness, and this puts it in context in some following slides. Over 8,300 children hospitalized. At least 94 of the deaths, at least in that period of time, have happened in the 5 to 11 age year group. And MIS-C, which is that big inflammatory syndrome that causes severely ill children. Thankfully, most are survive through wonderful medical care that happens at our children's hospitals, but they are severely ill, has happened most frequently in this age group. And of course, secondary transmission from kids to at-risk adults to other at-risk children, etc., is a very real phenomenon. So the real question everybody's asking is, okay, should I get my kids vaccinated? They tend to be mild. Why would I need to be vaccinated in those children? Well, in the state of Texas alone, the state of Texas just published this when this came out, we've had 22 children die from COVID. We've had 118 with MIS-C. Now, that's not a massive number, but I mean, one child age 5 to 11 of course, is one too many. And if we could prevent those deaths, why wouldn't we? And I'll show you some more data around that in a second. To put it in context, we have a number of vaccines that have come out over the last couple of decades, in several decades in some cases here, that, are severe illnesses, right? I mean, I personally, as a physician and a parent, am terrified of meningococcus, which is, a meningitis when you're, and it's the classical age group as your kid goes off to college. And kids die within 18 hours, 24 hours when they get this. But it's 8 deaths a year. But all of us celebrated that was there. And I can tell you, we ran out and got our kids, because one kid that age who's otherwise healthy is that many too many. And of course, you see varicella, et cetera. So you see COVID really at a significantly higher level on an annual basis in this age group than any of those other diseases that we have commonly accepted and commonly utilized vaccines now with our children. This is actually a breakdown that they showed in that meeting of age band of who died among children 18 and younger. And actually, you see the 5 to 11 really did fairly well compared to some other age groups. As you get older, and of course we've had vaccine for that group for a while now, we saw more children dying from COVID-19. They acted a little more like adults. What you also see, though, is look at the less than 1 year group. It's the biggest group. And so the infants, the children, we probably will never get protected by a COVID-19 vaccine, are the most at-risk group. So who does a 5-year-old or a 7-year-old or an 8-year-old live with? They live with their older brother or sister. They live with their 6-month-old brother or sister. And so protecting the community, protecting them, protecting their grandparents and others is critically important. But note that 1.7% of the entire deaths that happened in the United States were among kids who got COVID. So many other reasons they died, but it caused 1.7% of their deaths. And in fact, if you look at pre-COVID, the top causes of death in children, far and away, of course, accidents, right? And you can see the rate per 100,000, and you can see the number of deaths. It's pushing 1,000 people. But you can see COVID-19 slots in about number 7 or 8 in terms of the causes of death of children in the 5 to 11 age group. If I could take a vaccine and prevent any one of those other top 10 there, flu we can, not all pneumonia can we, why wouldn't we want to do that, of course? And so I firmly believe this is the right thing to do for children. The American Academy of Pediatrics has come out very strongly for this. If I had a child in this age bracket, y'all know my youngest is now, as of last week, 16. She was in the Moderna trial as a 15-year-old. And got the Moderna vaccine as part of the trial, I would be vaccinating my children given all of this information. The one final thing to show is this MISC. If you look at the graph on the bottom right, the majority, the highest number of cases, let me put it that way, have happened in this age band. And these kids are critically ill. They're in the hospital sometimes for weeks on all sorts of life support. In almost any era of medicine would have died, but thankfully, obviously, we have such sophisticated medicine now. Almost all of them, not quite all of them, do pull through, but it is a horrific thing when it happens. It's about 1 in 3,000 cases, and I don't know about y'all, if I could prevent that kind of horrible outcome at a 1 in 3,000 odds, I'll take a vaccine every single day as a physician and as a parent. And so some data, because I know a lot of you have children, grandchildren, are wrestling with this, but our experts really do believe this is the right way to go. The pediatricians, Texas Children's, Memorial Hermann Children's, others are all actively working to say, let's get our children vaccinated. I want to talk about a couple other things that come up frequently. Dirk will actually show some data around this. We get asked all the time, well, I've had this infection, should I get vaccinated? And there's a lot of conflicting information out there, but the CDC actually just came out with a very good study that showed unvaccinated individuals who previously had COVID versus people who'd been vaccinated and previously had COVID were 5 times as likely to, not who'd previously had COVID, versus people who'd been vaccinated were 5 times as likely to get COVID. Dirk's shown this data before. My kind of rule of thumb is having had COVID sort of like getting one of your vaccine series, and you really need to get the second and probably at some period in time a third. And so we do strongly recommend that anybody, whether vaccinated or unvaccinated, gets another shot, at least one, if not the full series moving forward. I put this here just so you'll have this in your materials. It's been a little updated since last time because we had some more approvals. They were just kind of happening the last time we were talking, but this really clearly will state for you, should you get a booster, who can get a booster, if you want a booster but you don't quite fit a category, can you get one with a prescription, which for Pfizer you can. And so hopefully you'll find this useful. Dirk will talk about this as well, but I love this graphic so much, it's so useful. This came out of the Wall Street Journal, and this is the mix and match efficacy graphic. So in the left, you see if you got a Pfizer dose, what happens then if you get either Moderna, Pfizer, or your booster dose is J&J. And basically, Moderna and Pfizer boosters, both highly, highly effective. 32x, in fact, with Moderna, 20x with Pfizer. Not nearly as effective, although still a nice boost with J&J. But look at the upper right in particular. That's J&J. If you got your one dose of J&J, which they're now saying, very emphatically, that should be a 2-dose series. But even that second dose of J&J only bumps your antibody levels by 4x, whereas you get, into the 10s, 35, 76. I'm not sure there's a meaningful difference between those or not, but the bottom line is, although it's not the official recommendations out there, really think long and hard about whether you should switch to that booster being one of the mRNA vaccines in that scenario. What you see with Moderna, which had a more robust immune response early, is not much difference with particularly which mRNA vaccine you get after that. So feel free to mix and match if it makes more sense. And if you have J&J, you may want to seek that out as your strategy. So kind of ending my talk about COVID, we now have admitted over the last few days, end of last week, our 25,000th hospitalized individual, which is just a mind-boggling number. Thankfully now it's a small number each day, 127 people obviously still in-house, over almost 60,000 people that we've diagnosed with COVID. But I want to talk about some other aspects of what's going on here, kind of, building on some of the amazing things we heard today. Our vision for our second century remains unchanged. It has served us well every step of the way. 6 simple words: unparalleled safety, quality, service, and innovation. I want to show you some of the things that kind of support that from the outside world. I tell our team, look, we don't chase awards. If we focus on the fundamentals, the awards will follow, and they've been following, even in the midst of a very difficult pandemic. So U.S. News & World Report, as you probably saw this summer, for the 5th time in our history, the 3rd time in a row, we are on their honor roll. We were the highest we've ever been at number 16 in the country, and every single time it's ever been measured, we've been the number 1 hospital in the state of Texas. They measure 4,750 hospitals, so incredible work. And to the kind of work you saw my colleagues doing, there's only a small handful of hospitals in the country that can do the kind of work that they talked about, and we are very privileged to be among that very small list. The people who work with me closely know the thing I pay the most attention to is a group called Vizient. This is a group where all of the academic hospitals, but for 1 or 2, St. Luke's in town because of their parent organization chose not to be in it, but really everybody pretty much else in the country is in it and shares data that's very standardized. And it gives us an ability to really look at, okay, so how are we doing on something that matters a lot, this safety feature, this mortality, some other quality metric, and when we're not doing well, to say who's doing well and compare notes. And so it's kind of a friendly, let's all rise all boats with the tide, but also a friendly competition. And if you look at that top line, every single one of our hospitals this year, this is the first time we've pulled this off, is blue. That's our color coding, Methodist blue, for the top 10%. So every hospital we have is in the top 10% of their respective groups. 6 of the 7 hospitals are 5-star, which is the absolute highest group. Clear Lake is top 10%, but the cutoff for that was the top 15 hospitals or so in their group. There's about 230 hospitals in their group. Number 1 on mortality at the main hospital. Number 1 in safety at the Woodlands. The Woodlands, the number 1 hospital out of about 120 in the complex care side. And in fact, in their top group, we were number 1, 4, 8, and 9. I mean, so tremendous, consistent performance. Now you see down below in some of the other areas, there's always work to be done. We're competing with the best of the best around the country, but I'm really proud of what our teams have accomplished. And remember, this is all during COVID, as all of these things that we've had to deal with. And in Houston, Texas, I can tell you we've had way more COVID than most of the people that are in this survey that are in other parts of the country. Not all, of course, but most. Leapfrog is an employer group that measures hospital safety. You can see it's twice a year. So for the last 5.5 years, straight A's. We had 1B at Clear Lake about 3-4 years ago. Tremendous consistent performance for each of our hospitals in this area. And again, with that consistency, that focus on the fundamentals, if we look at the main hospital, this is the honor roll hospitals, the top 20 in the country. On the left, we're number 16. You look at that the Leapfrog, which I just showed you, you look at those in Vizient 5-star at the right that I showed you, and then CMS, Centers for Medicare and Medicaid Services, ranks hospitals as well. We get 5 stars. There's only 5 hospitals in the country in this group that are that consistent across each of the major metrics. It's the Mayo Clinic, NYU Langone, Stanford Health, Houston Methodist Hospital, and Rush University Medical Center in Chicago. So again, tremendously excellent consistent performance. Thought I'd show you just a couple interesting stats I shared recently with a leadership team retreat we were having with the executives of some of the success factors. Both of the gentlemen you heard from today are in our physician organization. Our physician organization continues to grow academically and continues to be a place that many outstanding physicians in town say, I want to sign up, I want to be part of this. And we actually crossed our 1,000th physician in the physician organization just this last month, which I remember when we had 0. So, it's quite something. And it's been a 15-year journey. And we project this will continue to grow massively, been a major part of our success. And let me be clear, we have a very pluralistic model with many amazing private practice physicians. One of the ones you mentioned doing that major skull surgery there with you, or no, it was yours with Carolyn Thomas, is one of our private practice ophthalmologists that does a great deal of work with us. But this has been a big piece of our success as well. Our innovation portfolio really shined during COVID, continues to drive very rapidly in how we make innovation central to the patient experience, the patient journey, and I'm just excited by many things that are happening there as well. And we continue to put DE&I at the center of everything we're doing. At that focus, it's really demanded by our culture, our faith basis, our eye care values. Tremendous work under the leadership of our board committee. Mary Daffin, many of you know, chairs that. As well as Arian Dowdell, who's our chief DE&I officer institutionally. I'm very excited. If you look kind of towards the right hand here, we have started a training program very much modeled after much of what we've done to build our culture around our eye care values and around the unparalleled safety, quality, service, and innovation. We're using a very similar process. We've already put through 3,500 or so employees in just about a month and a half through that training, and very excited about all the activities happening there. And then to wrap up, we have throughout this process tried to be very crisp in our communication, set ambitious, difficult to achieve goals that pushed us during COVID. And so really as we think to the future now, moving into endemic state, been doing much messaging, and it's just starting, but much working with the executive team. And one fundamental thing right now, we're picking up a lot of the pieces of COVID. This has put many stresses on the hospital industry. I was at a meeting with a lot of CEOs last week, and to a T, every one of us is pulling out our hair with how do we get enough qualified staff on board? They're just not there. They've been leaving the profession. They're tired. They're fatigued. They're traveling. There's many things going on. And how do we effectively develop a group of talented employees and a pipeline of talented employees, but also how do we make sure that we are able to always have those on board? And one of the things, as we do pick up some of the ramifications of COVID, really clear with my team, it's always going to be a reason, right? COVID-19 happened, but it will never be our excuse for why we need something's working or not working. And we will be addressing all of those things aggressively as a team as we really bring people up moving forward. As we set, and there were detailed goals with the executive team, but as we set some of the high level things we're talking about, that unparalleled safety, quality, service, innovation works, and we will continue heightening our focus, doubling down on that. If you look at COVID, while it doesn't define our strategy, we do have to plan that it will be in some endemic fashion here with us for a foreseeable future. And of course, always in the back of our mind, knowing it can get out of that realm again, and we have to be prepared for that as well. We've had many strategies that have been working very well. Obviously, our focus on safety and quality and service and innovation, our building of hospitals, our growth of hospitals, our building of the physician organization, our accountable care organization, our academic institute, and all the amazing things happening there. All of those are critically important, and pushing and accelerating our work on those, and then really continuing some of almost the gift we were given through COVID. I hate to say it that way. We'd never have wanted COVID, but this institution has shined. The people have shined. Our structure has shined. It's been a proof point for our academic structure. So pressing our strategic advantages, really differentiating ourselves locally in our market, but continuing that differentiation nationally and globally that we have, I think, achieved so well throughout COVID. And then finally, I just want to talk briefly about our employees. I'm really excited that for Thanksgiving, we are giving every employee a $500 gift card. That's the gift card on the left you see there. It's a gift card to H-E-B. It wraps up, folds like gift cards do, in the middle one there. Every one of them with a note in my chicken scratch there, thanking each of our individuals for everything they did. And these folks here will know this. Normally we exclude all our executives, we exclude all our physicians, and this is really about our line employees. But this time, given everything everybody's been through, I wanted all of our employed physicians, our executives minus me, everybody is getting this as an acknowledgement and a thank you for everything that's happened. And I wanted to read you a note I got from a nurse, because we've talked so many times about how important y'all have been in helping with the morale and with kind of propping people up. And this was a nurse out in Baytown. It's kind of an interesting place to get that, since that was, one of her colleagues out there that was so noisy about our vaccine mandate. And she writes to me and says, Dr. Boom, I'm so thankful to work for Houston Methodist because we've been supported fully throughout the entire pandemic, both at and outside of work. And she's talking a bunch about all of you and all the things you've done. Methodist took care of me when I had COVID, and I received my full pay when I was out, which is a huge blessing that many people in the country did not get. Methodist also has done a lot to support us emotionally and assist us financially throughout the pandemic. And I, for one, was so grateful that Methodist secured vaccines as early as they did. Thank you. Thank you for the free mental health visits you encouraged us to take part of during the worst of the surges. Thank you for the extra pay incentives that I hope helped keep our employees while so many other healthcare workers were lured out for travel pay from other institutions. Thank you for the extra paid time off for our Heroes Day and the new extra holiday that we can use to support our own personal cultural celebrations and observations. Thank you for increasing our pay accordingly to match the market and other hospitals without us even having to ask. All of our perks do not go unnoticed, and there are reasons why there are so many lifelong employees who will be proud to retire from here one day, myself included. So, the stories we hear from our staff, the differences these kinds of bonuses make, our ability to do that, your support that enables us to be so effective and successful, greatly appreciated. So God bless each of you. Thank you so much. I'm going to shift to Dr. Sostman now, who's going to talk about that endemic phase, how we live with COVID, kind of a user's guide of some of the things that we can all do as we sort of seize the moment that I'm talking about, hoping that this moment lasts, for good, but really acknowledging and recognizing that we can't let our guard down fully, and we need to continue to do the right things. Dr. Sostman.
Thanks, Mark, and congratulations on everything that you've led the hospital to do. I do want to give a shout out and a thank you to Gene and Mike. The surgical skill is obvious from the results they showed. What you didn't see, we see every day, is what great guys they are and the humanitarian stuff they do. And thank you for taking the time to be on the program today. Really appreciate it. So, back to COVID. But as Mark said, this is hopeful. How do we live with COVID? Well, this is not the right way to do it. You don't do what Colorado's done and have a free-for-all, which has led to their ICUs being full, even as the ICUs here in Houston are emptying out. You don't focus on the alien abductions and why COVID shots don't work from the National Enquirer. So what do you do? Remember that regardless of what infectious disease you're talking about, the principles to control them, combat them, and avoid them are really all the same. The details vary, but first you want to keep the infectious agent from contacting your body. So depending on whether if you're talking about a respiratory infection, you do respiratory precautions, you wear a mask. For an enteric infection, you focus on hand hygiene, but you basically use precautions. If you do get contacted by the virus or the bacteria or whatever it is, if you're vaccinated, you've got a leg up on fighting the infection. If you get tested early and there are treatments available, you can get treated early, and all those things will enable the disease to be controlled. So how does this all fit together with COVID? I can't go into the details of everything in the available time, but I'll kind of hit the high points. So first off, preventing infection. COVID is a respiratory disease. It's mostly airborne, mostly droplet. The fomites, the droplets that fall onto surfaces and so forth are not a big factor. You don't have to scrub your groceries, just wash your hands frequently. The key thing is, try to do a lot of stuff outdoors, try to ventilate your home well or your office or your workplace. And in a high-risk situation, wear a good quality, well-fitting mask. And when do you want to mask up? You just use common sense. Are you going to be really close to other people for a really long time? Are you going to be at choir practice where they're like singing right next to you and blasting out those aerosols? Or are you going for a walk in the park with your significant other? I mean, it's pretty clear, I think, when you have to be most concerned. And the great news is this is not just for COVID. This works for all respiratory diseases. The orange graph on the left-hand side is for influenza. You see these spikes every year as the flu season comes across. But if you look at the very right-hand side of that graph, 2020 to 2021, it was like it ran into a brick wall. I mean, there was basically no influenza around the world. Why is that? Well, we think it's because of all the precautions people were taking. Everybody got their flu shots, they were wearing masks, they were locked down, they were socially distancing. On the right-hand panel in the blue is a much rarer viral disease called acute flaccid myelitis, which is also transmitted in a respiratory mode. Same thing, 2020, 2021, just disappeared. So these precautions really work. Vaccines are obviously critically important. And there's now a raft of data in clinical trials, real-world evidence. Just show some very nice data from the CDC, and thanks to the New York Times for this graphic. The top panel in the red is cases, with the dark line in vaccinated people and the lighter red line in unvaccinated people. And the difference between the height of those lines is the effect of the vaccine. So you can see that you are very, very protected by this vaccine. Even during the surge of the Delta virus, the Delta variant. And in the bottom, you'll see in the black curves, the death rate. Again, the dark black line is in the vaccinated people, the lighter black line in the unvaccinated people. And you can see that, oh my goodness, you're very safe from death from COVID when you're youngest. By the time you get to my age, it's a very substantial risk. And in the 80-plus, unvaccinated people have a staggeringly high death rate. Vaccinated people, although There are breakthrough cases, and certainly the higher risk you are, you can certainly still have serious illness or die. The protection is tremendous. Not Captain Kirk's invulnerable force shields, not a silver bullet, but a really, really effective vaccine, a really important tool in living with and managing COVID. So far, it looks like it's only the older population who is susceptible to severe disease, as protection from the vaccines normally wanes with time. We're keeping a very close eye on this and hoping that the good effect in the younger population continues to remain. As Marc said, people who've had COVID are somewhat immune. The CDC data that Marc showed shows that unvaccinated people with a previous infection are 5 times more likely to have a positive COVID test compared to vaccinated people. You'll hear different numbers from different studies. Some will say that vaccination is better. 1 or 2 have said that infection is stronger protection. The difference in these studies, number one, vaccination provides a much more specific, precise kind of immunity than infection does, probably a stronger kind of immunity. Infection gives you a broader but much less standardized dose, and some people who've had previous infections are highly immune, other people with previous infections less so. So as Marc said, we kind of rule of the thumb think of a COVID infection as equivalent to 1 dose of vaccine. Personally, even if I had 2 doses and a previous infection, I would probably still strongly consider getting a booster shot, but you may consider post-vaccine infection as a booster if you prefer. Here's some really interesting data, and if you have vaccine-hesitant friends, I encourage you to tell them about this. This is the likelihood of a close family member who's not vaccinated coming down with COVID, depending on whether other members of the family have been vaccinated. So the left-hand panel shows these 2 curves. The top curve is if nobody in a 2-person household has been vaccinated, that's the likelihood of somebody coming down with COVID. The lower curve is if one of those 2 people has been vaccinated, and you can see it is much less likely that either person, including the unvaccinated person, will come down with COVID. And there's actually what we call a dose-response curve here. The right-hand panel is 5-person households, and with each additional person who gets vaccinated, the unvaccinated people are more protected. So if you're trying to convince somebody to get vaccinated who's hesitant or afraid of it, you can say, if you don't want to do it for yourself, do it for your family. Marc's already covered the stuff about kids 5 to 11 extremely well. I'll just point out that my 7-year-old granddaughter got her first shot today, and she asked me to tell all of you that even if you're afraid to get it, you should get it. Booster shots, I think before long everybody's going to be eligible for a booster. The future most likely includes additional booster shots in future years. I don't know if this is going to be every year, if it's going to be every few years. Is it going to be tailored shots for new variants? These details are unclear, but I'm pretty sure we're going to have boosters going on into the future. The real-world evidence from Israel shows On the left-hand slide, the green line is people who were vaccinated, and you can see the dramatic decline in COVID cases in these folks. And the black line, with a lag time, even unvaccinated people started to have fewer cases as people got booster shots. Mark showed this graphic already. He sent it to me and I stole it. So I guess I deserve having him beat me to it. But you know, the unseen part of the iceberg here is the cell-mediated immunity part. What we're able to measure easily is antibodies. As you know from some of these other sessions, cell-mediated immunity is also really important. And that may be in part some of the difference between the J&J vaccine and the other two. The J&J vaccine seems to be biased towards what's called Th2 responses, where the cell-mediated immune component is a little stronger than the antibody component. But really the mix and match is clearly a viable alternative, but probably not a really big advantage, except in the case of if you've gotten the J&J, probably getting a booster from either Pfizer or Moderna makes sense. We had a lot of questions about antibody measurements and how to tell who's protected and who isn't. Sadly, we really don't know. Population-wise, in groups of people, we can say, well, if you've had 2 doses of vaccine, your odds are this. If you've had a 3rd dose, your odds are that. If you've had COVID in the past, your odds are something different. We can't really tell you precisely on an individual basis what your degree of protection is. The best group or population level measure is the titers or actual measurements of the levels of what are called neutralizing antibodies. It's a subset of your antibodies. Not all antibodies are neutralizing antibodies. But the data that we've accumulated here through our convalescent plasma program shows us that the overall antibody titers that a lab can measure correlate very well with neutralizing antibodies. So the higher your antibody titer, the better protected we believe you are. Does that mean that you should run out and get your antibodies measured and either despair or, go to choir practice a lot more? Not really, because we don't have data on person-to-person correlations between antibody levels and likelihood of getting infected. And also the levels change over time, as I think you've heard many, many times or read in the paper. The half-life is, several weeks to a couple of months. It normally declines. And so if I get my titer measured a month after I get vaccinated, and it's 1 to 1350, that doesn't mean that 6 months later it's still going to be that. It's going to be much lower. And we don't have a standard time to make these measurements and correlate them with protection. And then finally, although our lab here at Houston Methodist provides quantitative data, most commercial labs only report sort of semi-quantitative values. So we don't recommend that individuals try to use antibody measurements as a means of telling them whether they're susceptible or not to COVID. Big exception would be people, organ transplants and people who have immune compromise. We do measure their antibodies. Outpatient treatments. Early outpatient treatment of susceptible individuals is key here. You all have heard many, many times about monoclonal antibodies. I won't go into these details again. As with any COVID treatment, it's early, A, get a test, be sure it's COVID, and B, get treated early. Mark showed you some of the data from the Merck and Pfizer drugs. Here's some of the actual numbers. The Merck drug for the placebo group. The placebo group had 14% hospitalization, and 2% of people died. That was cut in half in terms of the hospitalizations, and there were 0 deaths in the treatment group. No safety signals. It worked for all of the viral variants. And as Mark said, it's just been approved in the United Kingdom as a treatment. The Pfizer drug, perhaps even more impressive, 89% reduction in hospitalization, 0 deaths compared to close to 2% for placebo. Really, really impressive. And if you look at this little diagram of how COVID actually works inside the cell, if you follow the red arrow and the green arrow, you can see that these two drugs work on different steps of the process. And just as we do for HIV, it's quite possible that combining these drugs could provide even better results. So very, very impressive. Let's talk about repurposed drugs for a minute. Ivermectin, it's interesting. I've had a number of people who are really, really intelligent people, very successful in what they do, make really basic errors of logic talking about ivermectin. And I think it's just that people have been so desperate for something to work. Well, we now have real drugs that have been shown in real clinical trials to work. So I predict that the interest in ivermectin is probably going to wane. And actually there is a really interesting repurposed drug called fluvoxamine. It's an antidepressant that in 2 different clinical trials now has been shown to have very good results in reducing bad consequences of COVID infection. So certainly worth further research there. And then finally, testing. We now have FDA-approved in-home tests available. They're less sensitive. They're not the gold standard of test accuracy. But if you have an active acute COVID infection, you're going to have a lot of virus, and these tests have a very good chance of identifying it. And this has the potential of keeping you away from other people who you could infect inadvertently, and to indicate to you that you really need to get treatment right away. So we're now with COVID entering an era where we have a similar situation to what we do with flu. In flu season, you take a lot of care to wash your hands and stay away from people who are sneezing. If you're feeling bad, you can get a flu swab. Everybody should be getting flu vaccine, and there are antiviral drugs that you can take to reduce the severity of the illness. We're entering that era now with COVID, and in fact, our vaccines and potentially our drugs are actually better than they are for influenza. So the tools to control COVID exist, and they're going to keep getting better. So if we use them correctly, consistently, follow the science, COVID's going to be a controllable, I won't say just a nuisance because it's more serious than that, but it's not going to be the monster that we've lived with for the last 18 months. I think it's really good news. So thank you.
Thank you, Dirk. That is good news indeed, and I love your optimism. I share your optimism. As I talked about before, we don't have a crystal ball, but right now what we see looks pretty good. And those drugs, when we can get those approved, can make a transformative difference for us. And so it's pretty exciting. You did, as always, such a great job that some of the questions we have teed up here, I think you've answered in great detail. So I will probably, in the interest of time, skip over a couple of those questions. We also have a couple that have come in today. I'm going to start actually in the interest of y'all's time, but one question came in about the PEG, as that was so impressive, and the specific question is, could that be used for something like spinal cord damage? And they're asking specifically for spinal stenosis, but It could be more broad than that.
Well, at this point in time, really, the technology is designed for acute injuries, so the injuries that happen within a 48-hour time frame. That's what we're really looking at now, and that's where it seems to be most effective. Whereas with the spinal stenosis, that's more of a chronic long-term issue. That being said, there's a lot of interest and enthusiasm with this technology with acute spinal cord injury as well, and that's going to be studied very heavily.
Great.
Yeah.
Okay, great. Well, Dirk, I'm going to ask you another one that came in, which was a good question, and sort of logically, if the vaccine is so safe, which we firmly believe it is from all the scientific evidence, but why didn't we have it that all ages would get it at once then, if it's so safe?
Yeah, it's a good question, I think partly relating to our regulatory process. I think the reasoning would have been that COVID was much more severe in older people, so the vaccine needed to be applied to them first. And secondly, from the clinical research ethics point of view, children are viewed as a quote-unquote vulnerable population. And you're always much more persnickety about doing research on prisoners, pregnant women, children. And so, the flip side, of course, is that for pregnant women and children, they can sometimes be left behind in getting the benefits of some of these research questions. So it's a tricky issue and a great question, but I think fortunately we're now there that everybody is able to get the vaccine.
Yeah, and as you say, that's pretty standard in medicine, unless other than some drugs that are obviously specifically targeted at children or a childhood disease, most things get studied in an adult population and then kind of, treed down in terms of age, which is exactly what they've done here. I mean, first 12 to 16, then 11 or 5 to 11, and now potentially younger than that as well at some point in the future. Okay, so I'm going to move quickly through some of these questions. Okay, so this next question, what are the predictions for another wave of COVID? I've touched some on this, but I want to answer that specifically. Obviously none of us know for sure, and I want to always caveat what I say, but in Texas, in Houston, where we've had such high prevalence of disease, where we have a fairly good, nowhere near as good as the best states and not even remotely near the best countries, but still the vaccine rate, the combination of those two, now you're adding some children into that and getting further protection. I do think we're going to have a decent winter, most likely. We're going to live with COVID. Life's not going to be normal, let me be clear. But I do think, given what you've been watching here, is, we have a very open society and we are right now managing through COVID. I suspect that will not be uniform throughout the country. That's always been the nature of this pandemic. Some of the colder areas may struggle a little more than we do, and sometimes that can kind of bleed back onto us. And so I wouldn't be surprised to see some uptick, but at least the best projections, IHME is usually decent, is suggesting it should be relatively in control. Again, all of that is off the table if a variant raises its head somewhere. With previous variants, knock wood, they've arisen somewhere else and we've sort of seen them coming. Didn't honestly, understand how bad Delta would be, but we saw that coming. We, knock wood, don't see that coming right now. And of course, that's constantly being watched out in the community. So are there other, there was the World Series, you guys are flipping on me here. Was the World Series a super spreader event? Obviously when you see all those fans packed in, nobody's wearing a mask, everything else, it always raises concern. We've somehow as a society been getting away with that now for a little while here. I think we are just in that evolutionary phase of the virus where it's just down, and let's face it, no one has fully understood the dynamics of these surges. We understand in broad strokes. We also understand that many of these surges and super spreader events are somewhat random. So sometimes you can get just an individual who's infected, who's spewing out tons of virus. You can get people in the wrong setting, and you get some big events. And sometimes that's not what happens. So far, at least locally, we've knock wood, not seen any uptick as a result of that. We will watch that closely. But still, when you're in large group settings, we really would recommend still being cautious, thinking about a mask, other things, and of course all of that titrated a little bit with your own personal risk factors as well. So if you were due for a booster, Dirk, and when should you get that if you then get COVID? What would you do?
So if you're due for a booster because you had 2 shots of vaccine and it's been 6 months, and you were due for a booster, but then you got COVID, I would consider that kind of like your booster. Again, I don't see any reason why you should not then get an additional booster, but I would wait 6 to 8 months.
Okay. Logical advice. Stay tuned because more study will come out around those issues as well, and we will change those recommendations if needed, as we always do as we get better data along the way. We had one come in, Dirk, on the chat, which is if somebody's previously had COVID and they probably have a high probability of still testing positive, so they're shedding virus. I'm assuming this is someone asking who maybe, as you all know, some people have shed virus for 2-3 months sometimes after. I've dealt with a few patients myself like that where they're totally well, but every time we check later, they are still shedding some virus. Are they dangerous to other people, and what's the current CDC recommendations around people like that?
So if you had COVID, and we're not talking about you tested negative and you felt fine, and then 8 months later you got COVID again with maybe a different variant. That's a different story. If you had COVID and you're still testing positive, you almost certainly are not shedding live virus. It's probably RNA fragments or something like that are still hanging around. You're probably not dangerous to others. I would just, out of an abundance of caution, mask and distance anyway. The one exception would be if you are immune compromised. It is possible for you to be incubating live virus for very prolonged periods of time, and you should treat yourself as infectious and as a potential hazard to others.
Thank you. Okay, talk a little bit about half-dose, full-dose boosters. Pfizer's full dose, J&J's full dose. The booster now for Moderna is actually half dose. Can you talk a little bit about that? And then there's a question here, and we had that one graphic about, is there an advantage for Pfizer after you've had Moderna?
Yeah, so as I think everybody knows, there's a lot of stuff we don't know about the vaccines. Pfizer picked 30 micrograms of messenger RNA as their full dose. Moderna picked 100 micrograms of messenger RNA as their full dose. That probably has a lot to do with the fact that Moderna gives you higher levels of antibodies and seems to have more durable protection. We don't know that for a fact, but it makes sense. And so Moderna has throttled back to 50 micrograms of messenger RNA for their booster, and Pfizer's staying with 30. And I think that makes a lot of sense. I don't think there's any reason to necessarily try to get 100 microgram full dose of Moderna as a booster. And I don't think that there's a big advantage to mixing and matching the messenger RNA vaccines. No disadvantage, but not a particular reason to do it.
Right. And only one caveat I'll say to that is, if you're immune compromised, really that third dose is not really a booster, so to speak, but it's really the third dose in a series that you need. Yeah. So whether you're Pfizer or Moderna there, you're getting a full strength third shot. But that's because you've probably not mounted a good immune response, and we're trying to do everything we can to get you an immune response.
Good clarification. And in point of fact, if you're immune compromised and you've had that 3-shot series, you're probably going to want to think about getting a booster shot 6 months later anyway.
Right, and your physician can do that, certainly with Pfizer as an off-label use, plus minus on Moderna, but they certainly could give you an additional Pfizer booster as they're thinking about you as an immune-compromised individual going forward.
Yeah, the other news item to follow if you are immune-compromised is the use of monoclonal antibodies as precautionary prophylactic measures. The clinical trial data for that is really strong, and I think the FDA should approve that as an EUA before too long. Yeah. So follow the news. If you are immune compromised, perhaps you haven't had the greatest response to the vaccines, keep an eye on that and reach out to your physician as soon as that becomes available.
Yeah, and the other good piece of news is if we have one or both of those drugs approved, in terms of treatment, there's no theoretical reason those will work any differently in an immune-compromised or a non-immune-compromised individual, since they're direct antivirals and affecting the virus itself. So you'll also have that, hopefully, in your arsenal soon, if, God forbid, you get infected as an immune-compromised individual. Okay, I'm going to bring things to a wrap-up. I think we've covered this one here. Really, if you get infected with a breakthrough case, we sort of think of that as maybe your booster, and you're saying probably wait a few months, and you're probably pretty well protected for a few months until that point in time. And then, I think we've also talked really about the antibody loss. So I'm going to wrap things up in the interest of time, and we've covered really all the rest of these things. So I'm going to wrap things up now in the interest of time. Whoops. Apologize. And I want to thank each of you for attending, as always. It's really wonderful to see each of you. We feel your support tremendously. I hope you've enjoyed kind of seeing a broader swath than just COVID, and our goal is to continue that. Our next meeting will be Thursday, December 9th for the last town hall of 2021. It should be town hall number 20. And Dr. Ben Weinstein, who's our chair of psychiatry, will be speaking about mental health and behavioral health advances at Houston Methodist. Thanks for being here. I wish everybody a wonderful, happy Thanksgiving.